Thank you very much for that kind introduction. I'm a sleep specialist, and being a sleep specialist at times, you become almost a de facto chronic pain specialist. So, because pain and sleep don't really go well together. And I like what was said earlier about the toolbox, and sleep is one of the big chunks of the toolbox, which needs to be used properly and effectively. You have to kind of arm yourself with the information about sleep so you don't go down the wrong path of over sedation that's not being effective in managing your pain. We just heard a great lecture about movement, and if you're over medicated, it simply won't you won't have the same sort of movement and do other things you can to help your pain. So sleep is very important. So I'm going to do a summary right now. Because I know I have your most attention currently. Sleep is sort of a key part of the pain syndrome. They are inconsistent brain states. If you are in pain, you're not sleeping well. So, yes, you need to pay attention to all your sleep issues, but the primary thing is to find ways to control your pain, and then usually the sleep will follow. Look for other problems, with your treatment team. Sleep apnea, depression, anxiety are common reasons for not sleeping with pain that aggravate it. And get a referral to a sleep center. And unfortunately, in Alberta, it isn't always covered and available, but there are a couple of reasonable sleep clinics that do a kind of a whole holistic assessment in Edmonton and Calgary. I think the other thing is exploring medication with doctor, and I really like the point Claudine made about deprescribing does not mean stopping. And I think we have a fair bit of education to do with that, because a lot of doctors conflate the two. It's a matter of lowering, finding the right level, finding what's working, looking for medications that are helping all your issues, right? And often, a lot of the medications that are prescribed routinely for pain by most practitioners make you gain weight, which doesn't help anything with most people's pain. And really do understand the effects that certain painkillers can have on sleep and breathing. I think that's a under recognized difficulty of the opiate pain medications, right? I think that's a key point, right? And often you're doing more harm than good with some of the opiate painkillers, and some are better than others. And obviously, cannabis is going to come up as part of this discussion, and it can definitely be helpful, but only after sort of assessment of all issues. And I think Dr. Tangay was going to go over some of the kind of basics of cannabis for pain, but understand that cannabis is not directly helping your sleep, but can be helping your sleep if it's part of your pain toolkit. And have to integrate some behavioral treatment. We've heard this already today, and from a sleep point of view, review your thoughts about sleep. Sometimes we have some very unrealistic expectations. It is very similar to pain in that way, because you're not going to get rid of all your sleep problems. Otherwise, you'll be a zombie, right? You'll have to learn to live with some sort of sleep disruption. And, behavioral treatments, any behavioral treatment you do for your sleep usually can help. We'll talk about that as well. And, all the sort of activity, physio, these sort of non-medication things you can do for your pain are going to help your sleep. Because when you're adding a medication, you are sort of disrupting the natural sleep wake cycle. I think we often feel like, you guys are in the waiting room or now virtual visits, with the doctor, it's like they can't figure it out. They almost want to, like, basically get this quick diagnosis and quick solution. And all of you likely on this call know that's not the case. And that's the case for sleep as well. It's often a multifactorial process with some common underpinnings, and you have to kind of take it step by step. So, we kind of like a layer cake. Some people are genetically poor sleepers. There is a circadian rhythm, then there is the pain. You may have some medical conditions, so mental illness symptoms that may come from the pain or be comorbid with the pain, then a primary sleep problem, such as sleep apnea or restless legs, poor sleep behavior, stress, and you push those all together, and then you have a patient who does not sleep very well. So you have to almost pick it off piece by piece, and looking at these things that are around the pain can sometimes help your overall sleep. So for example, if you're having a depression, get that aggressively treated. If you have sleep apnea, get that aggressively treated. If you have poor sleep behavior, work on that. So this is expanding the toolkit to help your sleep, and the first step is to look at it in multiple dimensions. So if we look at the primary sleep disorders and chronic pain, and I will be around for questions for the question period, of course, later in the afternoon, and I will be monitoring the chat box as best I can during the day, in and out. So basically, you know, sleep apnea. And I think it's important to realize the severity of sleep apnea doesn't correlate with fatigue symptoms. So even if you have a mild sleep apnea, it may be worth treated. Now, if you're on certain types of opiate painkillers, it may kind of create a very complex sleep apnea that may not respond to treatment. And we'll discuss that after. Insomnia, fragmented sleep, multiple reasons for this. And it's really important to integrate some semblance of behavioral treatment for sleep. A lot of you with chronic pain may need to lay down and rest during the day. That's just the way it is. But I wouldn't do it in the bedroom, because then that throws off your sleep cycle and makes the bed a, not a foundation for good sleep at night. Restless leg symptoms, that's where your legs are very restless while you're sitting still. Often overlaps with, sort of nerve pain. Certain medications such as Lyrica or gabapentin can treat both. So often people have a dimension of nerve pain. They also have a dimension of restlessness that play off each other. Then there's sort of body clock sleep disorders, and pain really disrupts the body clock. So as best you can, rest during the day may be needed, but sleeping during the day usually isn't a great idea. Or taking a lot of heavy sedatives during the day, to control your pain, unless you absolutely need to. But this can throw off your sleep at night. Then there is a primary disorder of sleepiness. Narcolepsy is the most famous one. You don't usually see that, but sometimes what you see is you're sleeping excessively and all other issues are being ruled out. That's not just lying there, sleeping 12, 14, 15 hours a day. And that's often indicative of, not having the right medication balance, right? And these things, or, other issues going on. And finally, parasomnias are nightmares, night terrors, sleepwalking. They look very pronounced, but they're usually due to some other issue with the sleep. Can be seen from fragmented sleep, can be seen with various medications, and can be quite severe. So these are sort of the major sleep disorders, primary ones that you will see as part of that layer cake. Now, I'm not going to get into too much detail, but I think understanding that, perception of sleep, and that can be a big chunk of people in pain. You don't sleep well and you don't perceive it well. Perception of sleep relies on these sort of upward projections. Sleep is associated with deactivation of certain pain circuits. And this overlaps with brain structures that are involved in keeping us awake. You're not supposed to be sleeping when you're in pain. So it is basically almost opposite. Things that decline in activity and sleep overlap with structures activated in pain. So the more pain you are in, the worse your sleep's going to be. It's a simple biological fact. So, you have to get that sort of balance. And really, like I said, I can't say it enough, as best you can, digging into your pain toolkit is usually a primary thing of helping your sleep, without sort of over medicating or over sedating yourself. Pain and sleep are inconsistent states. So you have to pay attention to your sleep independently as best you can. Pain leads to sleep disruption. You wake up, you have less deeper sleep, you have more lighter sleep. And sometimes you see in chronic pain states an intrusion of the lighter sleep in the deeper sleep. And that all leads to waking up feeling very poorly or feeling like you didn't sleep. So you're almost skimming rather than going into a deep, restful sleep. So, to summarize, in chronic pain, the structure of the sleep is modified and there is fragmentation of sleep. And like I said, the reflex is to chuck meds at this, and meds for sleep don't really often work if there's an acute pain state, like they just sedate you. Like they partially remedy this, But like I said, it has to be done in conjunction with a pain management program. And often, at some point, especially with opiate painkillers, you can get actually worse sleep, and worse sedation. So I think it's really important to find that balance between pain treatment and oversedation. So if we look at sleep deprivation and pain, chronic pain activates sort of areas, responsible for the awake state. It dampens areas responsible for initiation and maintenance. The lack of sleep impairs healing. It's directly to pain. So it's a bi-directional vicious cycle that you have to attack at both ends. So sleep disturbances may lead directly to more pain and indirectly heighten the pain experience through our sort of adaptive mechanisms. So you'll perceive pain more strongly. So it's a really important vicious cycle to try and get out of. And looking at pain and sleep at the same time is important. And that does not just mean just chucking medications at it. So a picture version of that is you have this pain, you have sleep interference, and then you can have some mood and anxiety, and they all go round and around and around and lead to this functional impairment. And as we heard earlier today, it's a lot about function. So you have to find that sort of, right combination. You're not going to get rid of all these things. But often, this is a dimension. If you don't treat this aggressively enough, pain and sleep are going to be worse. So they all play off each other, and you kind of have to identify with the treatment team which area to kind of poke into. And more than all, you can see pain is on the top here for a reason. And these things are often secondary, but still important backdoor ways of helping the pain. So again, sleep interference can directly result from chronic pain. And basically, the gist is let's improve function by any method. And that could be maybe becoming less depressed, maybe deepening the sleep, if you can't do anything about the pain. But doing something about the pain is usually primary. So looking at this, and we'll probably go over this more in detail. You guys probably all know this, but just to understand, you have this mechanical pain, which can, kind of progress to a nerve pain. So for example, a disc herniation is a mechanical issue, and then that kind of progresses to a nerve pain, all points in between. Now, I'm saying this because I find the nerve pain part is not well identified by a lot of physicians. They're kind of over focused on the mechanical pain, and the nerve pain is almost as more disruptive to the sleep. Those of you who have suffered it before, the burning, the tingling, that's probably the biggest disruption of sleep. And I think that's an important point. So looking at that, definitely do tell your doctor, right? Because doctors tend to sometimes miss the nerve pain. They're a little over focused, like I said, the mechanical pain. This is just some of the list of the symptoms. This is a scale for diabetic neuropathy, a type of nerve pain, burning, cold, shocks, tingling, pins and needles. That has a slightly different treatment. And this is what often the type of pain that really disrupts the sleep. That's pretty clear because if you look at some studies, you can see the two most consistent nerve pain related symptoms were difficulty sleeping and the lack of energy and the drowsiness, right? Because it just disrupts your sleep so much. And then those of you who have a dimension of fibromyalgia, which is a name I dislike intensely, but we'll talk about that in a sec. Again, fatigue and not sleeping, are you basically sister and brother systems to the muscular pain that you have. And, it's a whole issue of chronic pain related fatigue. And it's important not to aggravate that by over medicating. And sometimes, in some clinicians, or at least in our clinic, we will use sort of stimulant medications so people can have a greater quality of life once other things are ruled out. So, like I said, I'm not a big fan of the word fibromyalgia. I think a better sense is, those of you who have been through the system, suffered these things, know that you kind of get labeled this diagnosis, that diagnosis. Really, at the gist of the argument, a lot of these sort of, pain syndromes, fibromyalgia, it's a central sensitivity, right? So basically, your brain has been oversensitized to pain and other sort of symptoms. And I think that's a better way to sort of understand that. And this comes with a disruption in sleep, and you can see how it overlaps with sort of the mental health disorders. So I don't think someone would really have this sort of fibromyalgia, irritable bowel. Like, yes, it's good to target these, but the gist of the argument is there's a central sensitivity that needs to be sort of dealt with both psychologically and physically. Because each of us is born with a different volume control for pain and sensory processing, and this is what kind of goes oury in various levels to various degrees with people with pain. And what they're showing now with sort of newer literature is this volume setting can certainly be altered by life events, stress, trauma. Post-traumatic stress can often lead to chronic pain. These sorts of things can really, really affect your pain and sensory processing. So when we look at sort of the mood and anxiety component, you end up with sort of three sort of pots, and obviously there's some overlap, but three overall sorts of pots. One is you have a primary depression, and then had some pain sort of on top of that. Secondly, you've had pain for so long, you just get depressed. That's actually probably the most common thing we see. And then there's sort of a kind of they run together. So, it's really important to realize that what your sort of history was and really outlining it with your sort of treatment team, because often one is focused on more heavily than the other, and they may be running bidirectionally. Why is it important? Antidepressants can destabilize mood and sleep. You may not tolerate them. There may be an element, we see this quite a bit in the sleep clinic, that you actually may have more of a bipolar disorder than a straight depression. And these may respond to other medications used for pain. And they often need sort of mood stabilizers, anticonvulsants, and plus or minus an antidepressant. And often, any sort of mood and anxiety treatment helps cope with pain. The perception of the pain. Your pain hasn't changed, but the perception of it and what you can do with it, and your sort of, problem solving abilities and using your toolkit improves significantly. If you got, it's great to have the 100 tools, but if you're too depressed to use them, or too over sedated to use them, it's not going to work out very well. So when we look at treatment for sleep or not sleeping, I think this is a very important point that I'd like to make to all of you here. Just because you get deeper sleep or are sedated, it doesn't mean you have increased function. So if you are doing anything for your sleep or taking any medication for your sleep, please make sure that it actually is helping you, because it isn't just sort of knock you out. Because yeah, we can do that, but that doesn't necessarily correlate to an increase in function. So I think that's important. And sometimes we see a lot of people with chronic pain that have been over sedated heavily. So we do our own type of deep prescribing in the sleep clinic, right? You're not taking everything away, but they're on all these sedatives because they're not sleeping. And yeah, maybe they're getting 2, 3 more hours, but they're just over sedated the next day, and their function has not improved. And is there another problem that may explain the sleep issue? I think is key as well. Like I said, any sleep intervention is increasing alertness and function. That is the end goal, not just hours of sleep. I've actually literally almost stopped asking how people sleeping. I am asking how are they during the day and how is the sleep contributing to that? It's a subtle but important distinction. So these are sort of the components of cognitive behavioral therapy for insomnia. Now, it is, not 100% available, but there are some online therapists. There are some excellent books. One that I usually recommend is called the Insomnia Workbook. Another one is called No More Sleepless Nights. So the core of this, yes, sleep hygiene is important. And you guys have probably heard that, but what's more important, really, what people miss is what's thing called stimulus control. It is not lying awake in bed for long periods, and that can be difficult if you have chronic pain. But the key is, if you have to lie down somewhere else, right? Don't spend hours in your bed awake, because that is going to shoot yourself in the foot forever sleeping well. Now, you can do a very aggressive approach, if the pain allows it. doing sleep restriction. And that's a program where you would actually compress the time that you're in bed to 5 or 6 hours until you start sleeping and increase it. That doesn't always work, but it is an aggressive program that sometimes works. You may need to look at relaxation techniques. I think that can be very helpful. Mindfulness, other things that have been seen to help in chronic pain. But I think the gist of it is it's number one and number five, if I look at it mostly. People have very, very dysfunctional beliefs and attitudes about sleep, just as they do with pain, right? And I think that can be a big chunk, and expectations are important. That's the summary of this, because if you slept all day or lying down all day, you sort of can't sleep. So, some of the key misconceptions that we need to change is you have to keep realistic expectation. Just because you don't sleep, doesn't mean you have these daytime impairments. There may be other explanations. Don't catastrophize. A lot of you on the line here have probably not slept well for long periods, but have still managed to live your lives. Uh, even though sleep is very important, don't over focus on it. Like, don't make it the sole focus of your existence. And similar to pain, develop some tolerance to the effects of it. You're not going to sleep perfect every night. Even good sleepers don't. um you know but don't cancel things. Still try to push through. That's a good way to start this process of getting healthy, sort of a healthier view of sleep. So if we look at sleep medication concerns, and I'm not going to go over all of them, I can definitely take some questions at the end in the question period. Consider the effects of sedatives. I think a good way to think about it is how much pain control are you getting from this medication that's giving you side effects? And that's a different for everybody. But if it's just sedating you, then it may not be worth it. Treat the pain, as I said earlier. You can control multiple phases. There is a pregabalin, or the other name is Lyrica, as pain and sleep, Cymbalta or duloxetine for pain and depression and anxiety. It's good to try to use these, medications that knock down two things. A lot of you have maybe tried them and not tolerated them, but if you haven't, that's something that should be looked at. Limit dosing during the day. Don't be on anything that's making you gain weight. That's just going to shoot ourselves in the foot. And again, like I said, and not a lot of physicians do this, but sometimes in our clinic or other sleep clinics, we will sometimes use medications that are for attention deficit disorder or stimulant just to combat the fatigue from the chronic pain when we've tried to optimize everything. So it's going the other way around. I've had far more success giving people more energy than just knocking them out, because you're only going to sleep so well if you have a chronic pain syndrome. And this, we want to avoid sort of piling on, like this guy, 4 or 5 meds that aren't really doing anything. So definitely do, in your own sort of plan, make sure that what you are taking is helping you, and have a very robust, you should be able to have robust discussions with your team if things are not. So we'll finish up basically looking at this concept. Um, you have medications that have a direct effect on sleep, but really, this is probably the better option. If it's decreasing pain, then it improves the sleep. Sorry, that's a bit of a typo there. And this is often where medical cannabis helps. It has a somewhat of a direct effect on sleep, but really its major effect, is if it's decreasing pain, inflammation, these sorts of things, that's how it's helping sleep. So just understanding that it isn't necessarily direct, although that may be what you feel. Looking at some of these, again, like I said, I'm not going to go over all of them. There are some old antidepressants, which are actually quite good for pain, but have a lot of side effects, including weight gain. There are low dose antipsychotics that are sometimes used. We don't usually recommend them unless you really failed a lot of things. Benzodiazepines, these are just sedatives. Cannabinoids can hit both, which is why they can be very useful in this population. Not a big fan of cyclobenzaprine unless you absolutely need it, because it really is can be quite sedating. You see, I talked about Cymbalta earlier. Other antidepressants definitely aren't as good for pain. Again, gabapentin and pregabalin, these are medications that help sleep and pain, but have their side effects. and sort of, your traditional sleeping pills, Zopiclone and Zolpidem. So usually we would move towards something that actually helped more than one thing, right? That's usually, we should be rational about this. And it's not usually the greatest idea to just be on sleeping pills that aren't having another benefit, to your other sort of symptoms. So it isn't the be all end all, but we all know there's people that have done well with this, and I'm a big proponent of medical cannabis. The other thing is we heard about deprescribing. If you can, use medical cannabis and reduce some of your sedative and opiate burden, that is actually a win for your sleep anyway, because and your next day sedation. So I think that's an important point as well. There's the initiation of the marijuana just by itself, or there's replacing. And I think it's a very good replacement. Initiation, I might want a little more workup, but if you're replacing something else, it might be a net win. So, summing up the data, it's not a first line treatment. The right amount in the right patient. Like I said, mostly if it's helping pain at night. Too much of THC can make sleep worse and has next day effects. CBD dominant strains are pretty safe to try. Others have their own risks. Um, you know, Overall, primarily used in people with sleep problems with other chronic conditions, palliative care, chronic pain, MS, these sorts of things. So again, for I think most of the people in the audience, it may be an option, but discuss it with your treatment team of where it would fit. Finish off with opiates. Opiates are not good for your sleep. They decrease your drive to breathe. They're not all the same. The partial opiate painkillers, some of the names are tramadol, Nucynta, Suboxone, Butrans, are much better for your breathing, and they're usually better for sedation. The full opiate ones, morphine, hydromorph, OxyContin, these ones are usually much worse. Combining an opiate and a benzodiazepine is usually not good. And if you're on high doses of Zopiclone or other sleeping pills, they can start acting like benzodiazepines. Sedation, decreased brain function, right, with opiates as well. May also lower your testosterone, which is not really healthy for sex drive. We heard about sexual health earlier. Opiates are not usually good for that. Again, really the summary is if you're going to use this, it should be partial opiates, non-opioid methods of pain control, and accept some pain and work with it. Balance the pain control, sedation, and sleep disruption. Like I said, the opiates really kind of can collapse the airway and create sort of sleep apnea. Again, just because you're obese doesn't mean you'll have it. It just has an influence. It's really the effect on the size of the airway, which opiates cause collapse of. And the partial ones, not as much as the full ones. I'll skip that. Sorry, just quickly make a point. So this is kind of a point of the full opiate, which is oxycodone, depressing the breathing, versus the partial one, which is tramadol, which didn't seem to depress it much at all. Again, it's not perfect, but it's a better option than going to the full opiate from a breathing and sleep point of view. So to sum up, sleep problems and chronic pain are almost always multifactorial. You need to look at multiple layers. Always have to do a cost benefit analysis, and you have a clear idea what's treated, what's helping you. It can get very muddled, and I think that's not good for anybody. Every part of treatment can play a role. Sleep medication only after ruling out other problems. Medication that are weight neutral and may treat some other symptoms or disorders that may be there. And like I said, cannabis can be helpful, but not usually a direct sleeping medication. And be cautious with the THC percentages. Opiates are good for some sort of pain, but are usually detrimental to sleep in many ways from a sleep point of view. And the partial opiates are probably better.